Hello, I'm Dr. James Thomas. The interesting thing about neurolaryngology is, to some degree, we're trapped in the Stone Age of neurologic analysis of the larynx. We still think of paralysis or not paralyzed for the general neurologic condition of the larynx. But there's actually a great many neurologic configurations to the larynx. And how I believe we can actually see them, and not only can we see them, I think we can see them better than we can detect them with an EMG. Essentially what you need for this is an endoscope to get inside and look at the vocal cords closely, a recorder because everything happens too fast to see with the naked eye, so you can look at it multiple times, and lidocaine, numbing so that you can get close to the larynx and see the details of the various muscles in the larynx. The basis for the ability to detect what is neurologically impaired and how it's impaired is that each muscle only has a single action. It can only do one thing, it can contract. And you have the ability to isolate that action by what you ask the patient to do while you're examining them. Then you need to elicit that action, that is, ask the patient to do something so that you can see if the action is being performed when it should be performed. And that action is only contraction, and it only gets complex because there are several muscles acting at once, but each muscle can still only do one thing, and that is contract. And each muscle has an appropriate time to contract. For example, when I speak, a muscle of adduction or tension would be firing at that time, or we would expect it to be. The examiner also has a way of knowing what normal is, and that is often because one side's impaired and the other side's working. You can compare side to side and see what the difference is. You can not only see visually what the anatomic difference is, but you can look and compare the timing. That is, are the two opposing muscles contracting simultaneously, which is what they generally should be doing. And you can compare that contraction to the expected function. In other words, you expect a certain muscle to contract when you're phonating, and you expect a different muscle to contract when you're breathing in, and that other muscle should be relaxed. When you do see an action or a contraction of a muscle when you don't expect it, that often represents reinnervation, specifically inappropriate reinnervation. That muscle may have been reinnervated by a branch of the nerve that wasn't supposed to go there. And the third thing to remember during neurologic diagnosis is the patient always wants to compensate. Even though they're coming to you because of an impairment, they still don't want to sound bad when you're looking at them, and they'll do everything they can to provide you with the sound that you're asking for. But your goal is actually to make them sound worse so that you can identify the problem. And so when you ask them to do something, you often have to reassure them that it's okay to sound bad during that action because that's what you want to see. And you have to know how to remove compensation, mainly because there are two muscles that are used for adjusting pitch during phonation. It's really important to either perform something at high pitch or low pitch so that you can remove compensation. Well, as a general overview, the 10th nerve supplies the muscles of the larynx and pharynx, and whenever you have a problem in the larynx, you certainly want to examine all of those muscles, starting with the palate, the pharyngeal branch, and the pharyngeal constrictor. And then the superior branch goes to the cricothyroid, the muscle for high pitch and for maintaining tension during loud phonation. And then the three branches of the recurrent nerve, which we'll be focusing a lot on. First, let's take a look at what we expect to happen when the cricothyroid muscle engages. It's supposed to elongate the vocal cords, so when we ask a patient to increase their pitch, we expect the vocal cords to lengthen. Let's take a look at what normally should happen. Then let's take a look at an example case where an individual had a total thyroidectomy, a loss of voice, and after recovery, he can no longer hit any high notes. here's a case where there's been an injury to one of the nerves, and afterwards she can only partially lengthen her vocal cords. Since this is likely a unilateral injury, there's partial but incomplete lengthening. We can fine-tune our observation about the cricothyroid muscle by assessing the differences in amplitude between the two vocal cords at low pitch and at high pitch. And that's because the tension in the vocal cords, when it's even, they will oscillate through the exact same amplitude. And when one side is tighter than the other, the tight side will oscillate through its axis, while the opposite side, which is less tense, will tend to oscillate only lateral to its axis. So if the cricothyroid muscle is intact, the tension will be the same between the two vocal cords at low pitch and high pitch. The amplitude will change on each side. And when one cricothyroid is weak, at low pitch, of course the cricothyroid is not engaged, so the amplitude will be symmetric. But when you go to high pitch, if one cricothyroid muscle is tightening, then we'll see that oscillation remain around its axis, while the side that is not tightening is loose, and the amplitude of oscillation will be lateral to its axis. Just that note again. Let's go through a few of the visual findings for recurrent laryngeal nerve injury. What happens to a thyroarytenoid muscle when it becomes partially denervated? One of the things we can see is fasciculations. If we get close enough, we can see that the muscle fibers are contracting spontaneously because they don't have good neural input. Another finding we have is muscle mass, and we can compare the muscle mass between an atrophic muscle or an injured muscle on one side and a robust muscle that's being used on the other side. In cases of subtle muscle atrophy, if you get very close to the vocal cords and you activate the PCA muscle and pull them to their full length, you can see subtle differences in mass between injured and uninjured cords. I strongly encourage you to use topical anesthesia. It does not impair vocal cord movement. It only desensitizes the mucosa. Another technique, when you aren't certain that you're perceiving something, is to look at a video recording, look at it repeatedly, and slow it down, stop it where you want it to get a detailed view of something. In this case, the thyroarytenoid muscle is atrophic, but we really can only perceive it well when the individual has sniffed in. With a recurrent laryngeal nerve injury to the thyroarytenoid muscle branch, we all try to compensate, and we do that because we have a cricothyroid muscle that can take part of the place of the thyroarytenoid muscle. That is, it can add tension and keep the muscles closer together. Your goal is to remove that compensation, and you do that by lowering the pitch. When you lower the pitch, the vocal cords come further apart, and the one that has a thyroarytenoid muscle weakness will go further laterally, have less tension, and the lack of tension can be very apparent as flutter at a very low pitch. There's an element of the examiner focusing their mind. In this example case, we're going to focus on a video recording. We're going to slow down the motion so we can focus on it. We're going to isolate one function, phonation, one pitch, low pitch, one muscle, the thyroarytenoid muscle, one structure. We're going to look at the central margin of the membranous vocal cord, and we're only going to look on one side at a time. And by using that focus, we're going to be able to see in the details what's going on with this muscle. Let's first focus our attention on the right vocal cord and watch how it oscillates relative to its axis. While the right thyroarytenoid muscle never crosses its axis, if we look at the left thyroarytenoid muscle, we see that it oscillates fairly symmetrically about its axis. And with a weak thyroarytenoid muscle, the lower the pitch, the further laterally it will oscillate. Following the principle that the patient never wants to sound bad, they will use supraglottic squeeze and a low subglottic pressure to prevent the vocal cords from fluttering. You can remove that compensation by having them speak loudly. And if there's a weakness, you can hear and visually see the flutter. Let's put a few of these techniques together to discover another muscle that's not functioning. Good, but low down. So phonation superficially looks symmetric, but let's look at respiration for any asymmetries. Focus on the range of motion of the vocal processes. Supraglottic squeeze at low pitch is not muscle tension dysphonia. This is compensation by the patient, and we can bypass this with topical lidocaine. We also hear the problem at low pitch, so we want to view the problem at low pitch. Again. Slow the video down. The left vocal cord is fluttering at low pitch, remaining lateral to its axis, and is bowed at the onset and offset of phonation. While she is topically anesthetized, though, let's also get a close look at what the lateral cricoarytenoid muscle is doing by looking at the configuration of the vocal processes in the posterior glottis. For this, you need to push the endoscope way back underneath the arytenoids. The left vocal process cannot rotate medially, it's canted laterally, and the right vocal process actually is crossing the midline. If you view the posterior commissure at low, medium, and high pitch, you'll see that the cricothyroid muscle helps it to compensate by pulling the left vocal cord straighter. So at low pitch, the left vocal process is severely lateral. The LCA muscle is also active during the expiratory phase of respiration, so that when you are breathing out, the vocal processes should come towards the midline. So if there's an asymmetry in the range of motion, you can detect a weakness. Activation of the cricothyroid muscle at high pitch can pull the vocal process back to midline, effectively compensating for a weak lateral cricoarytenoid muscle. A visual exam offers an even more precise exam than an EMG. Take this case where an ENT diagnosed paralysis. The laryngologist thought the same thing, but wanted to reassure himself with an EMG. And the neurolaryngologist said it was abnormal, and they gave the patient Botox. She did not get better. As a visual neurolaryngologist, though, we want to see both the bulk of the thyroarytenoid muscle and the details of the configuration of the posterior commissure. What are the lateral cricoarytenoid muscles doing with the vocal processes? And when we get that close, we can make out a number of other problems as well. You don't really need further assessment once you see scar tissue tethering the two vocal processes together. During a detailed examination, then, we want to differentiate between paralysis, a rather rare condition, paresis, and then probably the most common conditions of mixed reinnervation. And then we want to think about what would synkinesis visually look like and what would dyskinesis visually look like. While watching respiration here, we notice that there's tension in the right vocal cord, there's an unsteadiness, and if we watch for a while, we'll actually see some inappropriate movement, a twitch in the wrong direction. During inspiration, the posterior cricoarytenoid muscle activates and should pull the vocal process laterally. And in this case, we'll see that the right vocal process actually moves medially during inspiration. This suggests that posterior cricoarytenoid nerve fibers have grown into the lateral cricoarytenoid muscle, activating the lateral cricoarytenoid muscle during deep inspiration. This is the visualization of dyskinesis. That is, activation of the PCA nerve fibers not only doesn't open the right side, it actually moves the right vocal process in the wrong direction. With deep inspiration, we can see that PCA nerve fibers are actually predominantly innervating the LCA muscle. During calm respiration, there's clearly opposing input to opposing muscles, leading to instability of the right vocal process. In summary then, visual neurolaryngology is based on the proposition that each muscle has a single action and that the examiner has the ability to isolate that action and view it. Additionally, each muscle has an appropriate time to contract. You can identify that time both by what you try to elicit and by comparing it to the opposite side. Inappropriate timing represents reinnervation by an inappropriate nerve fiber, a crossover of muscle fibers after a nerve injury. And patients naturally try to compensate. Your goal as an examiner is actually to remove that compensation so that you can reveal the pathology. There are a range of findings in neurolaryngology. Visually, you can look for atrophy of the thyroarytenoid muscle and sometimes the posterior cricoarytenoid muscle. You can look for fasciculations in the thyroarytenoid muscle. You can look for fasciculations of the arytenoid from the lateral cricoarytenoid or posterior cricoarytenoid innervation. You can look for oscillation and tension differences in both the thyroarytenoid muscle and the cricothyroid muscle. You can look for a range of motion issues by following the vocal process, which identifies pathology in the lateral cricoarytenoid muscle and the posterior cricoarytenoid muscle. And you can look for lengthening, which can separate out differences between the cricothyroid muscle and issues such as fixation. Hyperactivation, specifically in the lateral cricoarytenoid muscle, is from crossover of posterior cricoarytenoid fibers into the lateral cricoarytenoid muscle. And the examiner needs to focus on timing, find out when it's inappropriate, and compensation, unmasking. There are 4 categories of injury: paralysis, which one might have upon initial division of a nerve, but is really quite rare because of reinnervation; paresis, which is a partial injury or an incomplete loss of function; synkinesis, when there has been opposing innervation. One muscle gets innervation from opposing nerve branches; and dyskinesis, when that reinnervation is uneven. One of the predominant ones is when posterior cricoarytenoid fibers go into the lateral cricoarytenoid muscle and move it in an inappropriate direction at an inappropriate time. The neurolaryngologist's tools are the video endoscope to get in and see the larynx, digital recording so that you can slow down movement, you can look at it repetitively, topical anesthesia so that your endoscope gets super close and you can see some of the findings we discussed, and vocal manipulation, that is asking the patient to do sniffing, phonation, so that you can reveal pathology. I'm Dr. James Thomas. Thanks for listening to Visual Neurolaryngology. You can download a handout that covers much of this information from the website voicedoctor.net.